Welcome to the MRCS Bite session on functions of the stomach. Today, we'll dive into this topic and explore the common questions tested during the MRCS Part B exam. For more information and full course, please visit mrcsbites.com. Reservoir and mixing functions. The stomach has highly distensible, smooth muscle walls, which relax on the arrival of a meal. Its volume can increase to 1.5 liters without an increase in pressure. The stomach undergoes peristaltic waves, which expel only a small amount of chyme into the duodenum with each wave. These waves, generated by inherent electrical activity in the smooth muscle of the stomach, combined with hormonal influences, help to mix the stomach's contents and produce chyme. Endocrine function. The stomach produces a hormone called gastrin, G cells of the antral mucosa. This hormone is released in response to the cephalic phase, controlling acid secretion in the stomach. Gastrin acts to increase the secretion of acid by the parietal cells in the stomach. It also causes histamine release, which potentiates the release of acid. H2 receptor blockers such as ranitidine and cimetidine reduce gastric acidity by blocking this mechanism. Exocrine functions. Acid secretion. 2 liters of HCl secreted per day. Converts. Pepsinogen to pepsin. The active protease. Converts ferric, Phe3, iron to ferrous, Phe2, for jejunal absorption. Creates an acid environment in duodenum to facilitate iron and calcium absorption. Acid also provides innate immunity to infection. There are 3 phases of control of acid secretion. Cephalic phase, initiated by sight and smell of food. Vagally mediated increase in acid production. Stimulates gastrin secretion. Gastric phase. Food present in the stomach causes chemical and mechanical stimulation. This causes further gastrin release, and reflexly, via vagal afferents and efferents, increases acid secretion. Intestinal phase. Duodenal distension and presence of degradation products bring about a reflex decrease in acid secretion. Hormones released that mediate this include secretin, gastric inhibitory peptide, GIP, and cholecystokinin, CCK. The goblet cells in the stomach produce mucus, which lines the gastric mucosa and prevents the formation of ulcers secondary to the acidity. Intrinsic factor. This is produced by the parietal cells. It binds to vitamin B12 in the stomach and is necessary for its absorption in the terminal ileum. Loss of the parietal cells and intrinsic factor by autoantibodies, pernicious anemia, or gastrectomy causes a lack of vitamin B12, an essential cofactor for red cell production. This leads to megaloblastic anemia. Resection of the terminal ileum, for example, Crohn's disease has a similar effect. Based on your knowledge of the functions of the stomach, what are the effects of a total gastrectomy? Early dumping syndrome. Food of high osmolarity, not mixed in the stomach, causes rapid fluid shift and oligemia. This causes fainting and sweating from hypovolemia. Late dumping syndrome, caused by rebound. Hypoglycemia, or high insulin levels experienced after a high carbohydrate load, is presented and absorbed by the duodenum. Similar symptoms to above. Pernicious anemia and iron deficiency. Anemia. Early satiety, loss of reservoir function. Bilious vomiting. Loss of pyloric sphincter. Hypocalcemia and iron deficiency. Hypochlorhydria. Reduced HCl secretion. Interferes with the absorption of calcium and iron. Gastric stump carcinoma. Cancers occur at the gastrojejunal anastomosis 20 years or so after surgery. This may be a result of chronic irritation of gastric mucosa by duodenal secretions. Gallstones, caused by decreased gallbladder motility, post-vagotomy. For more MRCS Part B resources, please visit mrcsbites.com.